This is a demonstration of the CSI orbital atherectomy device, or OAD, for treating peripheral artery disease. The OAD utilizes a crown on an eccentrically shaped drive shaft. The crown contains very small diamond chips which gradually sand away plaque. Due to the eccentric shape, it can treat an artery which is approximately twice the diameter of the crown. We will show the use of the OAD for treating a lesion below the knee. The location and severity of the lesion has been defined through angiography prior to the OAD procedure. Before introducing the OAD into the artery, a guide wire is advanced through the artery and past the lesion. The OAD is then backloaded onto the guide wire. The distal tip of the guide wire is larger than the lumen of the OAD to ensure the OAD is always on the guide wire. The guide wire is the platform around which the OAD orbits during the procedure. The OAD is advanced until the crown is positioned just proximal to the lesion. With the OAD in this position, ensure the guide wire is about 10 centimeters past the distal end of the lesion before activating the OAD. Saline will flow through a sheath covering the drive shaft of the OAD to lubricate and cool the device. Bench testing has shown the combination of blood flow around the device and the saline slightly lowers the temperature at the treatment site. For the initial treatment, the OAD is set to rotate at 80,000 RPMs. It orbits using centrifugal force to push the crown out against the lesion. This creates a lumen larger than the diameter of the crown. The crown is passed through the lesion. Each pass, distal and proximal, takes approximately 1 second. Multiple animal studies have shown the design of the OAD crown sands away the plaque while doing little or no harm to the native artery. Plaque is removed with each pass of the crown. Bench testing has shown that the particulate matter generated is very small. Approximately 99% of the particles are less than 7 microns, about the size of a red blood cell. All of the particulate matter measured was less than 20 microns, about the size of a white blood cell. With each successive pass, the amount of particulate diminishes as the lesion is sanded open by the OAD. The plaque material is small enough to pass through the capillary beds of the distal anatomy. Without removing the OAD, the physician can use angiography to determine if the lesion needs additional treatment. If more plaque needs to be removed, the speed is then increased to approximately 140,000 RPMs. This higher speed pushes the crown further into the lesion, creating a lumen larger than can be achieved at 80,000 RPMs. A new series of distal and proximal passes is started at this higher speed. As in the first treatment, the OAD will move through the lesion several times to continue debulking. Note the small size of the particulate matter created by the OAD. The particulate, which has been sanded away, appears very small in comparison with red blood cells and white blood cells. The physician determines through angiography if additional passes are required at the same speed or a higher speed, depending on the residual stenosis after each treatment interval. If needed, OAD speeds can be increased to approximately 200,000 RPMs. This will produce the maximum orbit of the device and create a final lumen that is about twice the size of the crown. Use of the OAD has produced a much larger lumen in the diseased artery. The physician will determine via angiography if the procedure is complete. If so, the OAD and guide wire are removed.